Okay, very good. Let us begin. So this one is all the stuff that I think is high yield questions that often come up. And I was going through the clinical scenarios, which I've never done before, and it turns out that actually they have practice progress questions in the clinical scenario stuff.
Did you not know that?
No.
Really?
So I was doing...
That's not all of them, eh?
Not all of them, only some of them. But one question I was looking at today had like 7 questions. I was like, this is amazing. But so it took me ages to do this tutorial because every time I start, I'm like, oh, questions. And some of them I've got in here because I thought they were really good, but some of them are really hard.
Yeah.
And I was like, I don't know the answers. But anywho, all right. First question.
Don't know.
A 75-year-old Māori man presents to ED. He's got central chest pain. Present for the past 40 minutes. Came on while he was resting. He feels terrible. So first question that we ask ourselves is what's going on? What does he have? Yeah, he's having an MI. If we were to confirm he was having an MI, what could we do? To confirm it though, how do we know he's got an MI?
ECG.
Yeah, nice, ECG. We could do what's a blood test we could do. Yeah, you can do heaps of tests. I was thinking, yeah, you could do angiography. That would be also for treating. You could do angiography, find where the narrowing is, and then you could stent it. But what I was thinking was troponins.
What about the D-dimer?
So D-dimer for people who are having a PE or a DVT. So D-dimer is clot. D-dimer we use for PEs and DVTs, and it is a measure of how much clot is being broken down. So we'd be using troponins in this case because troponin is being released by the dying cardiac tissue. So what medication should not be given to this patient? So if we go through all of them in turn, and then we talk about what it is. So what's aspirin?
Anti-inflammatory?
Yes, it is an NSAID, yes. And it also has anti-platelet. Yeah. What does it do?
It's
antithrombolytic. It stops thromboxane being released in the... Oh, hey. Yes, so do you think we should be giving aspirin to this patient? This patient's having an MI. Should we be giving aspirin to the patient?
Yeah.
Yes.
That's the only one that looks familiar to me.
Yes, we should be giving aspirin. So aspirin we should be giving, and the answer is what should we not be giving? So we can cross that off. That's not one of the answers. What actually happens is you give aspirin in the acute setting. So often the paramedics will give people aspirin to like chew on if they're going to be having an MI, if they are having an MI. Ticagrelor.
I don't know what any of those drugs are.
I recognise Ticagrelor. I don't know why.
So ticagrelor is antiplatelet, I think.
Oh, you probably
And
want to be giving them that.
We want to give them
With
that,
the MI.
yep, for sure. Enoxaparin.
Is that an infection, eh?
Yeah, it's one of our... Do you know what it is?
And alteplase or something?
So alteplase is different to enoxaparin.
Oh.
So that's one of our, I think, low molecular weight heparins. And that's, again, very useful anti... Yep, good. So what's dobutamine? It's an inotrope.
Oh.
So what do inotropes do?
Increase your heart rate.
They make your heart work harder.
Work harder. More chronotrope.
So why would we not want to give an inotrope to a patient who's having an MI?
Their heart's dying.
Yeah, their heart's
They're
dying.
not
Make
getting
it
enough
work
blood.
harder.
Yeah,
already.
so if we increase the demands on the heart, but they don't have enough perfusion in the first place, you're going to make the MI worse. So these other ones, aspirin, ticagrelor, enoxaparin, those are all part of the drugs we'll be giving in the ED setting, while the patient is either waiting for, they can have one of 3 things, I guess. 3 things can treat their MI. We can bust the clot.
Mhm.
So that's like streptokinase or anti-tissue TPA. We could do PCI. So that's using angiography and going up through, I think it's the femoral artery, right up, stenting and pulling out the clot. And then what's the last thing we could be doing? We could do cabbage. So coronary artery bypass graft.
Oh, yeah.
And taking an artery from somewhere else, or a vein sometimes, and making new blood supply to the heart.
What do you usually use? Like this, or when you're doing bypass?
In women, it's like one of the mammary ones, so I don't know what it is for dudes. That's a good question. Cool. So that question was essentially, dobutamine is an inotrope, and we don't want to give it. It's not helpful. Okay. Which areas of the heart does the left coronary artery normally supply? This is straight off one of the ones that Roger B probably wrote. So normally supplies the anterior 2/3 of the interventricular septum, gives a circumflex artery, and supplies sinoatrial node. Same things, but instead of supplying the sinoatrial node, it supplies the left atrium and the ventricle. Same as before, it gives the right marginal artery and supplies the left atrium and ventricle. It normally supplies the posterior 1/3, gives both sinoatrial and atrioventricular nodal branches, and mostly supplies the left and right atria.
That's right coronary.
Cool, so it's not D.
It's not D.
It's not C.
B.
Why is it not C?
The left coronary artery doesn't give the right margin.
Right.
Excellent. So why, if it's B, then why isn't it A?
It isn't A because right coronary gives the sinoatrial.
Look at that. Well
Look at
done.
that. That was way better than the last one.
Coronary, holy shit.
I'm schooled, man. When I did this morning, I got it wrong. I was like, I think it's A. No, I was wrong. Cool, yeah. And then I think you're right. I've just got notes about the questions here, and I'm pretty sure, yeah, the right coronary does the posterior 1/3 and supplies the right atrium and ventricle. And it also sends off the 2 branches to the SA node and the AV node. Okay, 82-year-old New Zealand European man is sent to hospital by his GP because of worsening shortness of breath and fatigue. It's been going on for a few weeks now. He has noted that his ankles are swollen and he reports he had a heart attack 5 years ago. Which of the following medications will improve his shortness of breath? Metoprolol, verapamil, furosemide, tamsulosin.
C's a diuretic.
Yeah. It's A, a beta blocker.
Yep, so A is a beta blocker.
Calcium channel blocker.
Yep, very good.
I have no idea what D is.
Anyone remember what D is?
No.
That's an alpha blocker. So A, metoprolol. Why would that not improve his shortness of breath? Well, it could, but what would we really be using it for?
We'll be using it for heart failure.
Yeah, you'd be using it for hypertension and rate control. Verapamil is a calcium channel blocker. Remember there's 3 types of calcium channel blockers? Do you remember this? So there's ones that work mostly on the peripheries, ones that work mostly on the heart, and then ones that work on both, because it's got affinity to the specific calcium channels that are either in the heart or in the periphery. So verapamil is only for the heart. Nifedipine is an example of one that's only for the peripheries, and can anyone remember the name of the one for both that has affinity to both?
I'm pretty sure we'll joke there, to be honest.
Is diltiazem, apparently, is the one that works on both. Sorry, my throat's a bit crackly. Oh,
Hey.
that's nice. Okay, that's a nice little message. Maybe I'll do this. I don't know. I'll talk louder. Sorry, Mihi. I'll do my best. Not really sure how we could improve it. Okay. Oh, that's nice. So polite. All right. What do we think? So, what do we think the answer was?
see.
Good read.
Yeah, very good. So, what's the mechanism of action of furosemide or frusemide?
Block the sodium potassium chloride channel.
Perfect. NAKCC in the
Loop.
nice loop of Henle, which causes
It's urine excretion.
no
water
reabsorption
water
of salt.
Yeah.
You can't reabsorb salt.
Salt like
Water
reduces
doesn't-
fluid overload.
Water can't be reabsorbed either,
Yeah.
so it all gets peed out.
Yeah.
And so you're reducing the water load in his periphery, so that's the swollen ankles, and the shortness of breath and fatigue is probably what?
Edema.
Edema, yep, perfect. Pulmonary edema. And if we did a chest x-ray, you would see like the pulmonary edema at the bottom base of it. And what would we hear if we auscultated his lungs?
Like would be a raggedy sound.
You'd hear
Fluid?
bibasal crackles.
Oh, okay.
And it would be bibasal. If it was only one side, if you hear like crackles and wheeze on one side, you'd be like, oh, it could be pneumonia or something more specific. But if he's got all of these symptoms and bibasal crackles and sounds on auscultation and percussion, it would be delta percussion at the bases. You could do all of your history and examination and know he needed furosemide without having to do a chest x-ray, which is pretty cool. Tamsulosin is an alpha channel blocker, but we don't use it for blood pressure. It is the alpha channel blocker we use for benign prostatic hypertrophy. So we don't use it for hypertension, but the other two are cardiac. Okay. I think, oh no, this is right. A 38-year-old Māori woman presents to your GP. She's getting really short of breath, even at rest. GP hears a cardiac murmur. They ask you to listen and suggest a management plan. What type of murmur is associated with aortic stenosis? A, crescendo, decrescendo, systolic murmur. B, pansystolic murmur. C, decrescendo, diastolic murmur. Or D, continuous murmur.
Yeah. Systolic murmur.
So, yeah, perfect first step. Aortic stenosis, is it systolic or diastolic?
Systolic.
Tell me why it's systolic.
Because you're forcing blood through a narrow hole when it's being pushed out in systole.
Excellent. So it's either A or B. And which one of A or B do you think it would more likely be? This would be kind of just, you would have had to read a textbook and be like, oh, that's how it was described in the textbook. But it's A. Yeah. So crescendo, decrescendo. So what does that mean, crescendo, decrescendo?
It's like it starts off really loud because it's a lot of blood in a small hole, and then towards the end there's less blood, so it'd be decrescendo.
Excellent. So I've also written down what the other ones, examples of the other ones. So B is mitral regurg or tricuspid regurg. So that's systolic murmur as well, and that's because during the contraction of the ventricle, when blood should be going solely through the aorta, it's instead going back up into the atrium, so it causes a murmur. A decrescendo, a diastolic murmur, would be aortic valve regurgitation. So during relaxation, when there shouldn't be blood going back through it, and that's during diastole, relaxation of the ventricle, diastole, blood's going back through the aortic valve because the valve is regurgitating.
Wait, it's what?
So in the normal heart, right, you've got your ventricle, aortic valve, aorta, and you've got contraction, blood goes through the aortic valve and systole, and then relaxation, blood flows backwards, closes the gate, no blood goes through. In regurgitation, blood goes backwards and can slip through the aortic valve because it's not working so well anymore. And so during relaxation, you've got like sound going through.
Yeah.
And then a continuous murmur, apparently examples are a patent ductus arteriosus in a baby or severe coarctation of the aorta. So there's always, as blood is moving through the aorta, there's always going to be sound because it's really narrow, so it causes a continuous murmur. All right, I was like, where's the question? A 64-year-old New Zealand European man is brought to the ED by ambulance. He's collapsed, temporarily lost consciousness, Observed to become pale at the time of the collapse. When his ambulance crew arrived, it was noted his pulse rate was very rapid, and his ECG is on the next slide. What is this arrhythmia? Wide complex ventricular tachycardia, narrow complex ventricular tachycardia, ventricular fibrillation, or atrial tachycardia? So when we look at an ECG, what are there are 4 things that I like to look at when I look at an ECG. The first one is rate. Is it fast, normal, or slow? So what's normal range? 60 to 100, exactly. And there's something like, I can't remember, you count this number of little squares and it's a certain amount of seconds, but I can't remember how to do that. Essentially, does this look fast or slow? Fast. Nice. The next one is rate. The next one is rhythm. So is this a regular rhythm or is it an irregular rhythm? It's regular, yep. What's an example of an irregular rhythm?
Fibrillation.
Which one? Oh, well, yes, that's true, both of them. A common irregular rhythm that you'll see all the time. Atrial fibrillation. Super, super common cause of an irregular rhythm. The next thing you want to look at is the QRS complex. You want to know if it's narrow or wide. So I think my rule is 3 or 4 little squares. If it fits in that, it's probably narrow. If it's wider than that, it's probably wide. And the next thing I look at is the P wave. Can you see it? Sometimes it's really hard to see a P wave when someone's tachycardic because the T wave masks the P wave, but you should always try and look for it. And then after that, those are the 4 main things that I look for. And then after that, it's the distance, RR distance and the everything else. What's it called? The one that you look at for patients who have QT interval, all of that stuff. But I normally just go for those main 4 because then you can pick up most things. So for this one, fast, regular. What about the QRS?
Is that good?
It's very broad, yep. And can we see any P waves? No. So you might, if you're a cardiologist, if someone was having atrial tachycardia, you'd be able to see little blips every so often, and you'd be like, oh, the atria is, going fast. But in this case, there isn't. It's completely covered up by the QRS complex. So, of all of these examples, what do we think it is?
A.
Wide complex, very good. What's an example of why someone would get a wide complex ventricular tachycardia?
Would it be
Oh, you guys haven't done
heart failure?
RBF yet? Oh.
No.
Okay, so you learn about this in RBF. When you have an MI, you've got a whole lot of scar tissue, and the scar tissue acts like a circuit. And so if you get an irregular ectopic beat, and the beat conducts itself around the scar tissue,
like a different circuit.
So you've got the normal sinus rhythm going, but then you've got this extra circuit going around, and it can cause ventricular tachycardia. But it's wide complex because it's not using the regular QRS, not QRS, far out, the regular His-Purkinje bundle, SA node.
It's just stuck to that little.
Yeah, so it's only going around the ventricle, going myocyte to myocyte, and that's really slow.
Yeah.
If it uses the His-Purkinje system, then it's really fast, and that causes narrow complex VT, is when it uses the His-Purkinje system. And an example of a narrow complex tachycardia would be like if someone had, and I think we did this in cardio, Wolff Parkinson-White syndrome.
Oh, right.
And so you've got that accessory pathway, and if the tachycardia goes up through the accessory pathway, down through His-Purkinje system, back up, then you've got narrow complex because it's super fast. Ventricular fibrillation is what you get before you die, and that's just the ventricle, there's heaps of little circuits all over the ventricle, and it's not contracting
So
at all.
what do you see on an ECG?
For VFib?
Yeah.
Lots of small, little, random.
Okay.
It won't be this big, broad complex, because this is a whole lot of muscle moving together at once, whereas VFib is muscle over here and over here and over here, and it's not at all conducted together. And then atrial tachycardia, you would see it would be
normal QRS, but P wave.
You would be able to see a P wave associated with it. Yeah, or it definitely wouldn't look like this. ventricular tachycardia. Okay. 39-year-old Samoan man presents with fever and lethargy for the past 2 weeks. On examination, he has fever, splinter hemorrhages, and an early diastolic murmur. That has nothing to do with my actual question, which is which of the following is not a diagnostic criteria for rheumatic fever? This person doesn't have rheumatic fever. He's got infective endocarditis, splinter hemorrhages. But he's got a fever, a murmur, which people with rheumatic fever sometimes have. So what of the following is not a diagnostic criteria for rheumatic fever?
Erythema.
Palmar erythema?
Mm.
What is it instead? Because you're right,
it's not
but
Palmar,
it's something else.
The
Is
other
it
one.
weird rashy
Yeah.
thing?
The blotches.
Is it a
I think
rashy
it's,
thing?
yeah, erythema nodosa, I think it's called.
Yeah, he said it was really rare.
Yeah,
Yeah,
so
we don't
the
use
first two, Palmar erythema nodosum and subcutaneous nodules, super rare. The major criteria are
History of R.
no. There's 3 things that are like classic. Pardon me?
Carditis.
Yeah, great.
Is that in the Ham's Korea?
Great, and arthritis, or
the
specifically
polyarthritis.
migratory polyarthritis. So you go, oh, my knee's sore, oh, it's better now, oh, but now my hip is sore, oh, now it's better, oh, now my elbow's sore. So migratory polyarthritis, although apparently it doesn't present like that all the time, but arthritis. And yeah, so the major arthritis, carditis, and chorea. And what's chorea?
Is that dancey thing?
Where they can't
Yeah,
sit still.
yeah, so they can't, yeah.
It's called like St. Vitus's dance or something. Where like this whole village all got it. And
Whoa.
they were all like, they all thought they had been like infected with like a dancing bug, but it was just that.
Oh, they
That's
all
why I
had
said
chorea.
that dancing.
Oh, that's really sad. Okay, very good. On the topic of endocarditis, how do we detect it?
The antibodies?
No. So we do a blood culture, but you have to do 3 blood cultures with a certain amount of time in between them, because you can have a positive blood culture and then your body gets rid of the infection. But in endocarditis, your heart valves have been infected with something. And they are avascular, which is silly because blood goes past them all the time, but far too fast to have any blood, like white blood cells, come see it. So they're avascular, and when they get infected, they don't get better. Your body can't fight it, and so they like make these. They're called vegetations, and they grow.
Oh,
That's
vegetations, I remember that.
It's RF.
Was that
No,
This is
that's cardio. That's cardio.
Do we do that in cardio?
Yeah.
so in endocarditis, and the vegetations are constantly dropping off bits of bacteria into the bloodstream. So you'll have continuous positive bacterial or like positive blood culture because you're always dropping off bacteria into the bloodstream. Whereas some people might get bacteremia and then they'll fix it, but you can't fix this one because the source isn't being fixed, and so you've got to give them antibiotics. And how do we treat rheumatic fever?
Antibodies.
Which one?
Penicillin.
Very good. How do we give it to people?
You give it. It's like a 10-year or something. Oh, intramuscular.
Intramuscularly for how long?
10 years or something.
Ages. Yeah. And why are we giving them penicillin?
No, the bacteria.
Grandpas.
Yeah, but why are we giving it to them even if they aren't infected with the strep at the moment? Prophylaxis. So it's kind of, I'm trying to say that like because it's a reactive thing, because you only get these symptoms when you've got the cross-reactivity of the antibodies for the strep attacking your brain and your heart and your joints. You need to make sure you never get reinfected. That's the whole point of the prophylaxis. Because if you got reinfected, it's not the infection itself, it's your response to the infection. So that's why they don't just treat it when you get it, they make sure you never get it. Every time you get strep again, you're just going to get more antibody release, more damage, worse outcomes. Okay, next question. A 60-year-old Indian man is brought to hospital by ambulance. He collapsed while out shopping and a bystander started CPR straight away as he had no pulse. He was picked up by paramedics after 12 minutes of CPR and took 8 minutes to arrive. Which of the following is a shockable rhythm? atrial fibrillation, ventricular fibrillation, asystole, ventricular tachycardia. So if we shocked everyone who had atrial fibrillation in hospital, we wouldn't be very popular. So I don't think it's A. I'm just grabbing my notes, sorry. Asystole, what does that mean?
No contraction.
Mm.
Yep. VTAC, can we shock VTAC?
Yes,
Yes, we
you
can.
can. Ventac's okay.
So we can shock VTAC. Can we shock VFib?
No.
The answer actually is yes.
Oh, really?
And then this is from someone else's notes, but actually you can shock both VTAC and VFib. When would we not shock VTAC? That's why that's up here. When would we not shock VTAC?
They're awake.
If they're alive, so you can't have VFib and be alive.
Mm.
Because
Okay.
VFib, you don't have any movement of blood through your body.
so
Whereas in VTAC, even though it's a terrible rhythm,
You're still
there's
going.
still pumping of the heart. So blood can go around.
It's just common sense. Fuck.
We can't shock asystole because, I mean,
It's something else.
they're asystole, they're like this.
Like that.
So you shock it and it'll be like, oh, anyway. Okay. A one-day-old Chinese baby, this is the hardest question, that's why it's the last cardiac one. We'll see if we can do it. A one-day-old Chinese baby girl is found to be not feeding well. On examination, she has systolic murmur, she's diagnosed. What is the most likely congenital heart disease to explain these findings?
C.
Why is it C?
I feel like it's the only congenital heart disease. It's cyanotic.
Oh, yep. So why would it be no pathology? There's one word in there that makes me go, okay, this is a problem. Cynos. So lots of babies actually have murmurs. And they have murmurs because they could have one or both, I guess, of two of the things on the board.
B and D.
B and D, yep.
They
So
haven't closed yet, so it's kind of normal. It takes a while to close anyway.
that's right. So she's 1 day old.
Mm.
Those two probably are still open, but teratology of fallow will cause cyanosis. Your answer was like word for word perfect.
Oh.
What is that?
Teratology of fallow is the only congenital heart disease that causes
Yeah, that's just what I
cyanosis
remember that it's the only
in babies.
cause.
And it's because my notes don't have enough information on it, but it's essentially because not enough blood is going through the pulmonary system to get oxygenated and then coming back into the heart. Most of the blood is just going straight to the heart and then straight back out into the extremities, and so there's no oxygenation, and so you get cyanosed.
Okay.
Very good. Alright. Respiratory questions. I don't like respiratory very much, so you guys are going to have to help me out as well. 65-year-old Tongan woman presents to ED, shortness of breath. She's always short of breath, but it's much more difficult today. Breath is at rest. Increase in daily sputum production. She has a 30-year PAC history of smoking. Which of the following is correct? Hyperinflation contributes to limitations in exercise tolerance. Long-term oxygen therapy is used to improve exercise tolerance. Only those who have greater than 15% improvement of FEV1 derive long-term benefit from bronchodilator therapy. Respiratory rehabilitation has been demonstrated to improve long-term survival of COPD.
Not B.
So let's go through the ones we know are not true.
Mm.
When do we give oxygen therapy?
Low oxygen.
When they're about to die. Yeah, it's
Yeah,
like
not, doesn't it?
real. If you're domiciliary oxygen therapy is when you give them an oxygen tank at home, and that's expensive and hard work, and you only give it to people who really need it. So those people aren't going to be going and running marathons anytime soon. So it's nothing to do with exercise tolerance. So not B. What about
Not D.
D? Respiratory rehabilitation has been demonstrated to improve long-term survival in COPD. Yeah, respiratory rehabilitation is more for like improving what you've got
Yeah.
while
It's
you've
not
got
gonna-
it. But it's not going to make, oh, but suddenly I've lived really long.
Yeah.
Because I did. Yeah, so it's either, the correct answer is either A or C. So
I feel like C, isn't it like 12% or something like that? Or am I wrong?
So I would say that everyone benefits from bronchodilator therapy.
Just one, yeah.
Not just people who have like a certain improvement. Bronchodilator therapy is a mainstay of COPD treatment. And so what's the example of bronchodilator? Yeah, subbutyl beta agonist, exactly.
Hyperinflation contributes to the limitations of exercise tolerance.
Well, that makes sense because COPD is hyperinflated.
Yes, correct.
Okay, there you go.
So I find these questions, especially for stuff I don't like, quite overwhelming. And so I like to go through it and be like, well, that doesn't even make sense. That's not true.
If I can't be bothered reading it, I'm just gonna.
Do you guys write on your booklets?
Yeah.
Oh yeah. all
Yeah.
the
So
time.
I would be like, right. I would like cross it off and be like, not true. Oxygen's
I
only
wonder
for
if
people
read
who
it.
old. Oh, I hope they don't. I write my shopping list in the back if I'm bored. I'm like, oh, what will I do after this? Yeah. So that's for these quite long questions. I like going through them and like writing all over it so that I go, okay, my reasoning makes sense. So I choose A. And I don't like it when they're like, which of the following is not correct, or like, which one wouldn't you use? Because that's more work. Because then you have to be like, well, that's right. Okay, 25-year-old New European woman who's recently moved into the area presents to a GP clinic with increase in cough and student production and small hemoptyses. What's hemoptysis? Coughing up blood. She has a history of cough and purulent sputum production since early childhood. So what's the most likely diagnosis?
Is it small?
Is it big?
Bronchiectasis?
Yeah.
Yep, so what is bronchiectasis?
Is it like close?
Is that atelectasis? Huh? Bronchiectasis.
But bronchiolitis.
You sound the same to me.
They all look the same. The last two.
So bronchitis. What's bronchitis? Let's break it down. Bronch.
That's the name of the bronchi.
Itis. Great. So bronchiectasis is long-term changes to the bronchioles and bronchi because of infection, because of bronchitis.
Bronchiectasis.
And bronchiolitis is inflammation of the bronchioles, but it's very common, much more common in children, in like young kids. So she has a history of cough and sputum production since early childhood. She's 25 and she's still got cough and sputum production. That's like I think classic bronchiectasis. So bronchiectasis is kids who live in poor housing, especially who get recurrent respiratory infections, which causes scarring and edematous bronchioles, and that scarring and edema causes lots of mucus production. So that's why she's always got a cough and always producing sputum.
Doesn't it have something to do with the cilia as well?
Pardon me?
Doesn't it have something to do with the cilia because they get the same thing in the pancreas?
Yes, yeah, and I'm sure that there is something to do with cilia, and that definitely rings a bell in my mind. Just check my notes. Why is it not asthma?
The blood.
Yeah, it's more the history. So if she had asthma, she'd have wheeze, it'd be on exercise, or if she like had too much like dust or something in her house in winter. Yeah, and the other thing I didn't say is bronchitis is more common in old people. It's like a COPD thing.
What's the point of having moved into the area recently?
Oh, it's like in the clinical scenarios, it'll be like not only all the stuff about the medical, but that it'll be like taking a good history from a new patient, or like blah 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 blah. So when I copy and paste the clinical scenario, it has all this other stuff as well. Maybe you live in an expensive area, but she was from a poor area, so she moved in and she's got this like disease that you haven't seen before. I don't know. Same question. Same scenario, different questions. What is not an appropriate investigation for this patient?
Why would you use urine?
Great.
Those are the
So CT scan is like one of the best ways to diagnose this, because you see the I think the swelling in the bronchioles and all of the. I'm not a radiologist, I don't quite understand it really, but CT is what you use to make sure someone's got bronchiectasis. Quantitation of serum immunoglobulins. Why would we want to have that test?
because of the history of bronchiolitis, bronchitis. You would be forming antibodies, right? And there'd be like excess.
Kind of. You're on the right track. I'm
It's
thinking.
like inflammation.
I'm thinking more of there might be. She might have an autoimmune disease that causes. That attacks your lungs and causes interstitial. It's called interstitial lung disease. Autoimmune cause. And why would I be checking her sweat electrolyte levels? Perfect. Cystic fibrosis, and in cystic fibrosis, and you have like that thick, horrible gloopy mucus, so you cough a lot, blood, get sick a lot. And you wouldn't do an MSU, but what I learned the other day is that you can do urine tests for common antibodies that cause pneumonia. But this isn't what she's got in this case.
Yeah.
But there might be a question next week Friday that's like, someone's got pneumonia, would you test their urine? And you're like, yes, I would. Because in the hospital they can figure out if someone's got pneumonia or not, like what they've got, what sort of pneumonia they've got. Okay, 17-year-old Tukalaan woman, background of asthma, brought into ED after having short of breath with associated wheezy breathing. She's distressed but speaking in long sentences. Which of the following is not associated with this mild asthma attack? Decrease in PaCO2, increased airway resistance, reduced FEV1, or reduced functional residual volume. So what do we know? When someone's got asthma,
they've got increased airway resistance.
They've increased airway resistance. Great. So it's cross B off. It's good B. Reduce FEV1. Great. So it's A or D. Awesome. I like it when it's one of two things. You kind of like guess nothing.
It's not associated. A decrease in
PaCO2. Now I think I would have chosen that question. Yeah. I think I would have chosen decreased PaCO2, but in fact the answer is D. Yeah. You don't have reduced FVC. I think you've got increased FVC because you can't breathe it all out. Yeah. But you're hyperventilating when you've got asthma. Yep. You're breathing faster, and breathing faster is associated with breathing off carbon dioxide. So she would have a decrease in PaCO2.
So you have more airlight trapped in there. So it would increase.
Yes, or it would be the same. I think you would have to have really bad asthma to have lots and lots of gas trapping. I think it's the same one. Yeah, okay. She is administered fluticasone. I don't know if I'm saying that right. What is that?
I don't know.
It'd be like a corticosteroid.
Very good. Inhaled corticosteroid. Administered that via a spacer. What are the following statements about this is incorrect? Because of the first pass hepatic metabolism, systemic bioavailability is reduced. Lung deposition is improved by using a spacer. Use of a spacer does not reduce the risk of oropharyngeal candidiasis, and use of the spacer reduces the risk of a husky voice.
Yeah.
You guys are crushing it. Why is it not A?
It's got something to do with the metabolism.
Because you're not eating it. You're not. It's not getting into your stomach, going through your blood system, moving through the liver, and then going to your lungs. You're like breathing it in. So, use of a spacer does not reduce the risk of oropharyngeal candidiasis. Apparently, it reduces it a little bit. Use of the spacer reduces the risk of a husky voice. You always get it. Well, not always. Husky voice is a common side effect of fluticasone, whether or not you use a spacer. It's because of the deposition, apparently, of it on your vocal cords. And you're not going to fix it unless, I guess, you put a tube down and pull it through. Yeah, so it's not realistic. But when you use a spacer, you breathe, use the inhaler, and it's all in this chambery thing, and then you're breathing it in, and then breathe out, and then you breathe it in again, so you're trying to get as much in as possible. But if you just go like this, you're just going to breathe it all out immediately and not breathe it back in again, because now it's out in the air. So I guess that's for that question. Okay, you visit an 80-year-old New Zealand European woman with the GP you were shadowing. She's fever and is coughing up purulent sputum. A mobile chest X-ray shows confluent shadowing in the left lower lobe and the left side of pleural effusion. Which of the following is not a common cause of community-acquired pneumonia? A. Streptococcus pneumoniae. B. Haemophilus influenzae. C. Pseudomonas aeruginosa. Or D. Chlamydia pneumoniae.
C.
Yeah, it'll be C.
Come on, heck. Yes.
What is chlamydia? Can you get pneumonia from chlamydia?
Yes.
Really?
Well, there's
There's not like just one.
yeah, there's
chlamydia.
not. It's like there's like
Is
chlamydia that
a
causes
sexually
STIs
transmitted
and no.
chlamydia? Oh, okay.
And then there's chlamydia that causes pneumonia. But like the most common causes are A and B. That's why they're A and B. Is strep pneumonia, Haemophilus influenzae. So this question is kind of a talking point about the difference between community-acquired pneumonia and hospital-acquired pneumonia.
Mm-hmm.
So pneumonia that you acquire in the community is strep, Haemophilus, less commonly chlamydia. Can you think of a possible other cause of a hospital-acquired pneumonia? Something that we always think about when we think about hospital and bed bugs.
Staph? No.
Yes,
Yeah,
MRSA. So
Yeah.
MRSA pneumonia, hospital-acquired. And the other one is ESBL, so E. coli, that's not sensitive to beta-lactamase. I think that's what ESBL. Yeah. And the Pseudomonas, I think it's like they did a test and like 50% it's like 99% of hospitals have Pseudomonas in the air and 50% of people staying in hospital have Pseudomonas in their lungs, something like that. So it's a common cause of hospital-acquired pneumonia.
So the common cause of the hospital ones are the ones that are resistant to stuff.
And very
ESBL.
different as well. So ESBL, MRSA, Pseudomonas. So this is a gram-negative as well. The other ones are all gram-positive. Streptococcuses. I don't know if Haemophilus is actually. Pseudomonas is a gram-negative, so it's E. coli. So they're
gram-positive.
But strep's definitely gram-positive. I can
Yeah.
tell you that. I
Oh.
can tell you that. And just I thought when I was writing this question, I thought of a relevant like story from the hospital, which was that the other day I was with my team. I'm on GenMed at the moment, which is why this is very, very helpful. And we had a 777 call for one of our patients. We ran up and she was saturations were 76% on air, and she was hyperventilating and she was feeling really dizzy and sick, and she had a high temperature. And so they did a mobile chest X-ray, and she had this huge lower left lobe pneumonia, and she did not come in with pneumonia. She got hospital-acquired pneumonia. Yep.
Do they get mad at the hospital when you tell them that you've
Yeah, 'cause you
acquired
have to
this
tell
in
them it's
hospital?
Well,
hospital-acquired
there's nice ways of saying it, because they'll say, while you've been here, you've just got a little tiny bit of an infection that will just clear up for you, which is way better than you have a hospital-acquired pneumonia. And you're like, it's all about how you say it. And then there's another patient under our team who had bowel obstruction, which was then fixed, but before she could go home, she got hospital-acquired pneumonia, so she's been here for like 2.5 weeks. Yeah. So it's a big deal. And I don't know the first thing about antibiotics, but the antibiotics you use are different as well to community-acquired pneumonia. Okay, 65-year-old Samoan man returns to GP where you're on your attachment. He's prolonged cough. GP arranges checks X-ray, 2.5 centimeter diameter cavity with an area of confluent shadowing in the superior segment of the right lower lobe. Direct examination of sputum shows acid-fast bacilli. What do we reckon he's got? TB. Which of the following is correct? A negative quantiferon gold test makes TB unlikely. He is not likely to be infectious. The lack of involvement of the lump apices does not exclude pulmonary. Oh, I should say pulmonary TB. Yeah, there's the answer. Because I got my question wrong. He'll require treatment of 3 to 4 months. Right. Sorry, I mucked that one up a bit, but should say pulmonary TB. So he is likely to be infectious. Yeah. Why?
TB.
Because he's got TB, yeah. But also,
yeah.
You can have other types of TB. You can have TB in your bone. You can have stomach TB. You can have brain TB. But you can't really like cough your brain, right? But when you're coughing and you've got lung TB, it's a no. So he's likely to be infectious. Quantiferon gold test is kind of bad. So a negative quantiferon gold does not make TB unlikely. It's not very good at. I think it's like not sensitive but specific, or not specific but sensitive, one of the two. And treatment is like 6 months or longer. And you take like a big cocktail of drugs. And apparently there's this new type of TB that lots of people have, which is like pan-resistant TB.
Wow.
Really hard to treat. Anyway, TBs are terrible. And in your books it'll say TB often causes cavitating lesions in the upper lung aphyses, but just because he doesn't have that doesn't mean he doesn't have TB. And the other thing that means that we think he's probably got TB is his ethnicity and age. So he's an older man from the islands, so that increases his risk of having TB. 7-year-old New Zealand European man presents to a clinic due to worsening shortness of breath on exertion. He ran his chest x-ray and shows a large extrapulmonary mass. Which of the following parts of his history is most important? His father died of an infectious exacerbation of COPD. He's of New Zealand European descent. He worked in the mines in Australia as a teenager. He has never smoked.
Could semen asbestos? No.
Yep, and what does asbestos cause?
Mesothelioma?
Which is an
Screen.
extrapulmonary mass. Yeah, so squamous cell. You wouldn't see the chest x-ray, it wouldn't be inside, the lung would be like you'd see on the outside. Yeah, it's very good. The he has never smoked thing is just to remind me to talk about, and I don't know this very well at all, but the cells that we get from smoke, the cancers, lung cancers from smoking and non-smoking are different.
Yeah.
So people who get small cell carcinoma
That's the smoking one.
are more likely, more likely that from smoking. And the other types of cancer are more likely to be in people who have never smoked. Okay, 55-year-old New Zealand European man collapses at work, sudden onset of right-sided weakness. Oh, this is neuro now. His wife tells you he has recently been had short episodes where he can't find the right words, he has hypertension, is reasonably well controlled, and has been a lifelong smoker. What is the next most appropriate step in management? CT head, ultrasound his carotid arteries, EEG, percutaneous coronary intervention.
Hold on. Right-sided weakness. Wouldn't you want to? I go for the head to see if he's still getting blood flow to that side of the brain, left side of the brain.
Yeah, so the answer is CT head. We could ultrasound the carotid arteries. We would do that later to make sure that he doesn't have stenosis in his carotid arteries or like some sort of big thrombus that's been building up and dropping off little bits of thrombus up to the brain. EEG is useless, but you can do an ECG to rule out any cardiac problems. And then percutaneous, I think coronary is the right word, but you can do similar to what you do in the heart, where you go up and grab the clot in the brain and pull it out. MRI, I think, is better for brain imaging, but CT is way faster. And if you can see the problem on the CT, then you can treat it. We can treat, if someone's got an ischemic stroke, we can treat it with what? So it's similar to a cardiac. You can pull the clot out, stent it, and you can also give, fibrinolysis, streptokinase sort of stuff. But the caveat to that is they must have started having symptoms less than, I think, 6 hours before.
Yeah.
Because otherwise, it's all risk-benefit analysis. Because what are some of the risks of giving this drug?
Bleed out.
Yeah, they bleed out. What if we gave someone who was having a hemorrhagic stroke
Then they bleed
streptokinase, right? That'd be terrible.
You're killing them. You just
That
killed
would be
them.
terrible. So we do a CT head so we can be like, oh, well, I can see that it's an ischemic looking stroke versus, oh, wow, there's a whole lot of blood everywhere in the head. Very good. Oh, and actually, just talking about, his wife tells you recently he has had short episodes where he can't find the right words.
Is that in one of the areas?
Yeah. So he's been having some sort of aphasia, but it's short episodes that come and go. What's that called? Yes, transient ischemic attacks, a TIA, a transient ischemic attack. So TIA is like the precursor to a stroke. So people who have TIAs are at much higher risk of having a stroke. And a TIA is like a mini stroke that goes away. So let's say that a clot goes, blocks off the circulation for a bit, but then your body clears the clot by itself and you'll come back to normal. That's a TIA. And so he's been having, his wife says that he's been having these TIAs that are resolving. Nothing's been done about it. He didn't go to the GP to talk about it. And now he's had collapse with sudden onset right-sided weakness that's not going away. Now he's having a full-on stroke. And so if we think about some of the possible risk factors for having a stroke, and then how we would treat it if we had the same guy come in, but he came in a week ago saying, oh, I've been having these short episodes, how could we reduce his risk of having this big stroke? Yeah, so anti-clot therapy, yeah.
Tell him to stop smoking. And treat
Yeah, very
hypertension.
good. Treat hypertension, stop smoking, aspirin, or put him on something. What we would put him on is dual antiplatelet therapy, which is aspirin and clopidogrel, and then you take them concurrently, and then you take off normally the aspirin and you're on clopidogrel or ticagrelor, one of the two, for long term. So that's dual antiplatelet therapy. And the other thing you'd want to give them is a statin. And you could also give them antithrombolytic stuff like warfarin or dabigatran. So you're like attacking this clot in all ways, trying to stop him from having any more strokes. All of this, of course, increases his risk of bleeding.
Yeah.
So that's a question they might ask in the progress. It would be like, Chad's VAS has bleed scores. And that's all about just thinking like, someone's at risk of stroke, so we're going to give them all these medications, but it also increases their risk of bleeding. Cool. A mother brings her 8-year-old boy to the GP because of a headache. He sees aura before the headache comes on, can't stand loud noises, often becomes nauseous. Which of the following medications will not be helpful for his symptoms of migraine? Or which of the following medications will not be given to him for his symptoms of migraine? Paracetamol, sumatriptan, metoclopramide, or morphine?
Metoclopramide and antiemetic.
Perfect. So would we give him metoclopramide?
Because he's nauseous.
Perfect, yep. Good. So we would give him C.
I don't know what B is. Sumatriptan.
So triptans help increase blood flow to the brain. And migraines are often thought to be all about like narrowing of the vessels of the brain.
So you would give that.
So you would give him that.
A.
You wouldn't want to give A?
Morphine's pretty intense to give an 8-year-old, isn't it? Or no?
Yeah, well, I think what this question is trying to tell us is that we don't give opiates to people who, especially are nauseous, but to people who are having migraines. The most common treatment's paracetamol and brufen, and it actually works quite well. The triptans are this newfangled thing that apparently work really well. Treat things like the nausea. Make sure that they're in a nice, quiet, dark room where there's no like intense stimuli to upset them. But I'm pretty sure I can't find anywhere in the literature that we give morphine, and I'm pretty sure that it's bad because then people get addicted to it. It's like again risk-benefit analysis. I read somewhere that ibuprofen has a number needed to treat of 2, which is amazing. So if you give 2 people Panadol, 2 people ibuprofen, one of those people will have a 30% reduction in their pain. And that was like their metric was like,
For migraine.
do you have 30%? I think it was for all pain. But
Paracetamol is only indicated for migraine.
pardon me?
Is paracetamol not even indicated for migraine?
I think you do give Panadol.
To see first.
What's our WHO ladder of our World Health Organization ladder of
Giving those kinds of drugs.
medication?
Yeah, isn't
Morphine.
morphine like one of the
That's
last
last.
steps?
That's one of the
Especially
last.
if they're 8.
It's codeine second. I think it's paracetamol.
So one
paracetamol
is
first.
Panadol and NSAIDs.
It's like
Yeah.
Trimble.
And then
What's 2? Yeah.
codeine. And then
I don't know how to spell codeine.
Yeah.
And then finally up here,
Morphine.
Fentanyl.
Oh,
Yeah.
They're always the last ones.
I was like working in the pharmacy over the summer, and we like misplaced a pack because it was like in the classified drugs, and they misplaced a pack of like 10 fentanyl syringes, and everyone was like freaking the fuck out, and I was brand new.
Oh no!
And so they were like, I was like, I've stolen your fentanyl.
So that's the WHO pain ladder, and we have to always remember that you must have your base medication to be able to put anything on top of it. So don't be like, oh, are you in pain? Have some morphine. You have to be like, are you in pain? We'll have some Panadol and some Brufen. Oh, it didn't improve? Have some Tramadol. Oh, it didn't improve? Take all 3 of those, and also we'll give you some morphine, because pain is multifactorial, and by targeting lots of different causes of pain, you're much more likely to improve it. And what I was going to say about when I was on my anaesthetic run, they were like, oh, give this patient, they were asleep under the anaesthesia, like, I'll give them some morphine, and they were breathing by themselves, and then he gave like, however much morphine you normally give, I don't know, and then the respirator just went like that, and then I was like, oh my god. So that's why morphine and fentanyl are so dangerous, because it causes respiratory depression. It was crazy. Okay, good, that went away. A 74-year-old South African male presents with sudden painless loss of right side of vision for 10 minutes. There's no associated symptoms and no past ocular history of note. What is the most probable cause of his symptoms? Vitreous hemorrhage, retinal detachment, TIA, left posterior cerebellar artery stroke.
It's just the eye.
Some painless loss of right side of vision.
I think I rewrote this question, and now we're going to have to know what the answer is, but I did. Yeah, sorry, it's supposed to be retinal artery occlusion.
So TIA.
Just think of that bit here. Yeah. So hemorrhage and retinal detachment cause, I think it's quite painful, but also the vision came back. It was only for 10 minutes and then it came back, so it's transient. So he's having essentially a TIA of his eye. He could have a left posterior cerebellar artery stroke, but that's why this picture's here.
You'd get it.
Because it's all about where, well, yeah, you would, yeah, but also it's all about like where you have your lesion. So here, the retinal artery, which is supplying just the eye, is affected, so it's just right eye. If he was having a homonymous hemianopia, what would that mean?
It's the optic tract, right?
Yeah, so homonymous hemianopia is anywhere from here backwards.
And is it like quadrantinopias are like really at the optic radiations? Is that the quad ones?
Yeah, here's our quadrantinopia, so they're like not the whole bundle coming through back through here. And if it was at the optic chiasm, remember the eye like comes through and then 2 bits of it decussate to come around the back, so that's when you only get the bits on the side. What was I going to say? Yeah, so that's just what you think about when someone's got eye problems. You'd be like, oh well, if it's only one eye, then it has to be forward from the optic chiasm. If it's the left side of this eye and the right side of this eye, that must mean it's at the chiasm because it's where they're coming across. And if it's all right-sided vision, then it must mean it's on the left side of the brain, posterior to the, yeah. So we can see here that 4 and 7 both cause the same defect.
Oh wow.
Because it's the same information, this is just a larger radiation of it. And 5 and 6 cause the quadrantinopia because it's only like half of that radiation that's been affected. Okay. 20-year-old Tongan rural community lifeguard. Just as an aside, I like how they put so much effort into it. A Tongan rural community lifeguard was brought to the ED after having an apparent convulsive episode at the lifesaving club. Her friends say she lost consciousness and was initially still before thrashing around. What best describes her seizure? Absent seizure, tonic-clonic seizure, atonic seizure, tonic seizure. Which one?
Not absent.
Yeah.
So what is an absent seizure?
So you're just like, It's when you just like zone out and then you come
Yep.
back.
Very good. Yep. Let's go through all the words. There's 3 different words here. So what does tonic mean?
It means that you have tone.
Hold tone. So
Yeah.
tonic is when people are like, and it's normally your flexors that end up being really increased tone. So you're like close like this. What's clonic?
Is that when you
Repeated
contract it?
large
Yeah.
contraction movements. Yep. Atonic,
No tone.
No, everything's
just
floppy.
collapse, no tone. Tonic, again,
Just stay.
just staying like that. So if someone lost consciousness and was initially still before thrashing around, they've probably got a tonic-clonic seizure because they were tonic
No.
and then they were clonic. Yep. So that's, I think, the best way. Yeah, so just going through the words like you guys were doing is exactly how you should be doing it. 45-year-old woman presents ED with the worst headache of her life. She was sitting at home watching TV, headache came out of the blue. She was in the recess, finds light very uncomfortable. Blood pressure is very high. What is the most serious possible cause of her headache? This is one of their important not to miss. Is it a subarachnoid hemorrhage? Is it a migraine? Is it trigeminal neuralgia? Or is it a tension headache?
Yeah,
It's a headache.
any
Shrug it off.
hemorrhage is like,
It's out of the blue and it's out of the blue,
Yeah.
Have the worst headache of their life.
So the classic thunderclap headache.
Yeah.
I'm surprised that in the story it doesn't have her like just falling, being like, oh, ow, my head hurts, and then falling over and losing consciousness. Trigeminal neuralgia, we haven't talked about that. What's that?
Do we have pain?
Irritation of the trigeminal nerve.
Yeah.
It's one-sided. It's like the most worst pain people ever have. I think they're like their eyes water heaps and they have like
That's the hypersensitivity.
yeah, and it's like
The
and the
pain.
question like, and that's why on Past Me it always says like they like someone breathes on their face and then they get pain. It's trigeminal neuralgia. I guess it's an ache in your head, but like
but not brain ache.
That's the real pain.
I guess it can cause because the trigeminal nerve also supplies up around here, but it would just hurt like a lot.
And what's I read that the other day, but I completely forgot about cluster headaches. Do you know
Great
about
question. I don't know much about them.
those?
Apologies.
I have no idea.
Are they the ones that people say are like?
Tension is more like in your forehead and it's constant. Clusters more happen in your eye and on one side of you. Oh, sorry, in your eye. And then migraines are like one half the other.
Let's see what up to date says. I think you're right about the eye stuff though.
The cluster ones, they come on.
Yes, that's why they're called cluster, because they come, you get like a whole lot in a few months and then none for years and then they come back.
That's right. Yeah.
Tension is more, it's like when you, tension is more like.
Is it the band one?
Yes, so
Yeah.
tension headache is what we get when we're tired and stressed and
Common.
upset.
Clusters like come on.
Yeah.
Like 5 minutes.
And it feels like it's in your eye or behind your eye.
It is, yes, intense pain around one of your eyes. It is the most painful condition known to mankind.
Wait, what is
What?
Cluster headaches.
Most painful condition.
known to mankind? Really?
No, surely not.
You just say trigeminal neuralgia.
Yeah, they're both painful, but
I don't know.
according to up to date, it's the worst pain you could ever have.
Okay.
Let's all hope we never get that.
Yeah.
Okay, this is the last one, I'm pretty sure. 48-year-old Māori man presents with progressive left-sided weakness. His partner tells you he has been increasingly difficult to live with over the past few months, with an inability to make decisions and is becoming increasingly forgetful. Which of the following primary cancers is least likely to metastasize to the brain? Lung, melanoma, colorectal, lymphoma.
Yeah, colorectal.
I feel like not lung. You say not lung.
Not lymphoma.
Lymphoma.
It doesn't mean
yeah.
lymph node.
Melanoma's-
The size of the bone.
I don't know. I guess if you get a melanoma here, it's going to go through the veins. You go straight in.
That's right.
That one metastasizes to the bone.
So, yeah, melanoma definitely does.
Colorectal. It's the furthest from. I'm just
Quite a
thinking like
distance.
quite a distance away, eh? So.
Through the lymph. Oh my gosh, take it. So the answer is actually lymphoma. Lymphoma causes about 1% of all brain metastases.
That's right.
Lung is like 50%. It's in order there of most common. And one of the answers was going to be breast cancer, but then I read the scenario again and it was like 40-year-old man. And I was like, oh, whoops. But breast cancer is also super common metastasis, and so is kidneys.
But what about colorectal?
Yeah, common.
Oh.
Colorectal cancer.
How though?
Yep, but this is more like, how do I put it? A large proportion of colorectal cancers will metastasize to liver, lungs, and bone. But of brain metastases, 10% of them are colorectal cancer, if that makes sense. 1% is lymphoma.
And also breast and
I wrote it in my
kidneys.
notes. Yes, and breast and kidney.
How many lymphomas? Well, obviously lymphoma. Like.
There's lung, melanoma, colorectal, breast cancer. Those are all ones that metastasize a lot. And bone metastases are the most common cause of bone cancer in adults. In children, the most common cause of bone cancer is primary sarcoma. But in adults, metastases are the most common cause of bone cancer. And that is quite similar. It's lung, colorectal, renal, breast. But the number one that we should always be thinking of in an older male with bone pain, prostate cancer causes bone metastases very often, especially like right next door in the last one. I liked your thinking. I think it's quite reasonable to be like, we would have metastasized and it was next door. Yeah, what's a way we can find metastases? If we want to stage someone, we think they've got a metastasis somewhere.
A marker or something? No.
Yeah, we can use blood markers, but blood markers don't tell us where it's gone.
Could you have them?
You could do an MRI.
Check them in the machine.
MRI. The other one I'm thinking of is CT scan, but the one I'm thinking of the most is a PET scan. Anyone know what a PET scan is?
No.
That's what you do.
Yeah. So my understanding is also really rudimentary, but a PET scan is when you give someone, like, I'm not going to say radioactive, but radioactive glucose, and then you do a CT image of them to see where that glucose is being used up the most. Because cancer uses heaps of energy, so it's going to use heaps of this glucose. So what you'll see, maybe I should find a picture.